So yes, most of us are doing the YAG laser peripheral iridotomy, and obviously in India we have a very high number of patients having an angle closure disease. And if we have a high number of patients having angle closure disease, if we go by all these population-based studies, then approximately 12 million people are having the glaucoma, and out of that, 1/3 of them are having the angle closure disease. So it translates into approximately 4 million. And if the 4 million people, they have the disease, then you can imagine that at least 3x would be a suspect. So probably the same number of patients, the glaucoma, 12 million, so probably the 12 million might be the angle closure suspect. And it is the only treatment which is a prophylactic treatment, like you give a polio vaccine and you have given the prophylactic treatment for the polio, and it is also called as a prophylactic treatment, the vaccinating the eye against the angle closure glaucoma. Two questions comes in our mind: when and how? So obviously, when, the answer is very simple. This is the continuum of angle closure disease, and we don't want our patient to reach to this stage or this stage or this stage or even this stage. And as I said that we have a prophylactic treatment available, then why not to prevent the patients to progress to these all stages beyond this? Just use a simple gonioscope. See, if you see that the angle is appositionally closed 270 degree, then it makes an indication to do the prophylactic iridotomy. If you see the blotchy pigmentation in the trabecular meshwork, there is an indication to do the peripheral iridotomy. If you see by Von Herrichs, the angle is very shallow and the patient complains of intermittent color halos and headache, in particular in the evening or so, then it makes a case. So there are so many cases where probably you can judge whether the patient needs the prophylactic iridotomy or not. But obviously, in all the patients, our objective should be, our goal should be to pick up the patients at this stage and try to prevent the progression to the subsequent stage. But if the patient has already developed the angle closure disease, maybe a chronic angle closure or might have had acute angle closure, that also makes the indication to do the peripheral iridotomy. So these are the indications. The PACS, the most common and probably the one which yields the best possible outcome of the YAG laser iridotomy, the PACS. In the PACS in particular, the most classical example of the PACS is the fellow eye. The patient have had a take in one eye and the other eye, Von Herrichs, is very shallow. Put the gonioscope and see that there is 100% indications to do the prophylactic iridotomy for that particular patient. The patient have had acute, break the acute angle closure attack and do the iridotomy. The patient had a chronic angle closure glaucoma, then also you have to do the iridotomy first and then proceed further. So I have already discussed this, that when to do a LPI if the patient is a PACS. So the PACS, if the appositionally 270 degree closed, then you have to do the LPI, and the other, the blotchy pigmentation, the family history of angle closure glaucoma is equally important. What is the outcome? If you do select a proper patients of a PACS and do the peripheral iridotomy, the outcome is pretty good. But they have done the longitudinal study of all these PACS. Obviously, the gonioscopy is a subjective procedure and it has a subjective bias. So they have done the study that out of these many PACS patients, how many would land up in acute angle closure. So they find out that approximately 5% of the patients who are diagnosed clinically, there might be a subjective bias involved. 5% of the patients would end up in an acute attack on 5 years follow-up. So somebody may ask, then why unnecessarily to do this procedure for every patient? So yes, you have to be very, very perfect in your gonioscopy, select, identify the appropriate cases which are likely to end up in acute angle closure disease, and you may adopt a little liberal approach because obviously it is more or less a harmless procedure. Apart from that, the pigmentary glaucoma, where there is an inverse pupillary block, the mixed mechanism glaucoma, the malignant glaucoma you do because it is the diagnosis by exclusion. Anterior chamber is very shallow, pressure is very high, you do the iridotomy, and if the AC doesn't form, then you diagnose it as aqueous misdirection or the malignant glaucoma. So that could be the one indication. And all of us knows that the nano-ophthalmic eyes are having a predisposition for development of the angle closure disease. Now the second question comes, how? So obviously, yes, the most of us, we do the peripheral iridotomy by the YAG laser. The Sushmita has already described about it. The argon laser was used long before, and some people are using both the lasers, particularly in a patient who have a very thick iris. They uses the argon laser to thin out the iris at the peripheral part, and then they use the YAG laser. But almost in 99.9% patient is done with a YAG laser. What is the procedure? You have to do the meiosis. The pilocarpine is must. You have to stretch the pupil. You cannot do a good peripheral iridotomy in the mobile pupil. Don't do it at the extreme periphery. If you do at the extreme periphery, then obviously there is a risk of the bleeding from the ciliary processes, and obviously these ciliary processes can block your peripheral iridotomy in future. So little anterior to the extreme periphery is the most ideal position. 10 to 12 o'clock is the most ideal position. And yes, you would like to give aqueous suppressant, either tablet Diamox or a topical beta blocker or the alpha-2 agonist. Epreclonidine now no one of us is using. The procedure is simple. You have to use the lens, either the Weiss or the Abraham lens. It not only prevent the blinking, but also it would focus to the crypt properly and deliver the optimal energy at the point where you want to deliver the energy. The single burst mode, 4 to 6 millijoule or so, 4 to 8 if your laser is old, is adequate. The end point is you just see the gush of the aqueous flowing from the posterior chamber to the anterior chamber along with the pigments. People says that the 50 micron iridotomy is good enough, but I personally feel that it should be large enough. Approximately 200 micron is good, because 50 micron probably may get blocked by the pigments and so on and so forth. So the end point is once you see the gush of aqueous along with the pigments, that's the end point. This is the procedure for the argon laser, and nowadays none of us are using it. Once you have done this, you have to assure that yes, this iridotomy is patent, and that you cannot do on the slit lamp examination, because most of this, the thinned out iris, will show a good retro illumination. The best is obviously the ASOCT, where you can demonstrate the patency of this, and once you are certain about that, then you can do a dilatation and do a detailed examination like you do for the other patient. And once you are done, obviously there will be an increased volume of the anterior chamber. What are the complications? The most important is the hyphema. Many of these patients, because of the collarate vessels or the ciliary processes, some bleed comes, but you just give a little pressure with the thumb and this bleeding stops. But the patient who are on the blood thinner, anticoagulants, or patients who are on dialysis, they are more prone for the profuse bleeding from these collarate vessels, and I have seen a patient with a full hyphema. So you have to be a little careful and probably take a due consent before that and do it. Corneal endothelium injury is pretty common, but it goes away in a couple of hours' time. Iritis goes away in a couple of days' time. The late closure of the iridotomy, yes, so every time you have to ascertain the patency of that. Now, the people have started talking of the temporal PI. The temporal PI, the concept is that it prevents the dysphotopsia. They says that the tear film meniscus acts like a base up prism, the base down prism, and because of that there is a dysphotopsia. So if you do the temporal PI, then there is the least dysphotopsia or almost no dysphotopsia. The difficult situation, the iris where there are no crypts are visible, you have to find, and sometimes you have to use the burst mode. If you use the burst mode, then you can penetrate the thick iris also with 1 or 2 shots. If the patient is having a NVI or NVA, just identify that where it is and don't put your laser mark over there. Obviously, the acute angle closer, you have to break the attack, you have to find the good place where you can do the PI, and many a time you have to do in 2 or 3 sitting. Don't make it as an ego issue that you have to complete today itself. Call the patient after a couple of days and then repeat and complete it. In the chronic angle closer glaucoma, yes, sometimes they are challenging, but again you can penetrate the iris comfortably. Acute angle closer, the most difficult cases, first you have to make the cornea clear by giving the IV mannitol and tablet Diamox, and put the pilocarpine frequently, constrict the pupil to the maximum possible extent, and do a good peripheral iridotomy, and then proceed further. All these secondary glaucoma, the uveitis glaucoma and these kind of secondary glaucomas are difficult, where you have to difficult to penetrate the iris, and iris bleed profusely, but you have to do, and you can get away comfortably if you have gathered enough experience. The spherophakia, it also causes the pupillary block glaucoma, and because it's a young patient, their iris is very, very thick, and it's very, very difficult. Acute ACG we have already discussed. So that is how we do the PI, and these are the difficult situations, and comfortably you can get away in these difficult situations as well if you have learned enough. Thank you very much for your patience hearing.